what was discussed on Monday or anything that wasn't discussed. Maybe that would be best, or maybe you have other ideas.
Yeah, so as I understand it, it's supposed to be more of a roundtable discussion today. So if you have anything that you didn't quite get to that you'd like to get to, or if any of the participants have questions or want to share, I believe this is about their QA practices at their institution. So if they want to share what they're doing or have questions about how to do something or best practices, then the floor is open for that.
Yeah, exactly. So this is Adam. Exactly. So we want to have a few of these sessions throughout the curriculum, just to give a time for all the participants to catch up. And so this is basically just a time that you all can ask questions about sort of anything that we've covered so far. Dr. Price is on the call. I'm on the call. It looks like we also have Cesar as well as Sanja. I think I saw you guys both on the call. So the four of us will be happy to just discuss your processes at your own hospitals, QA processes, IMRT QA, the bits of commissioning that have been covered so far. So it's just a time to help answer any questions to the best of our abilities. So I guess we can start. If anyone, don't be bashful. I know there are lots of things that you all are working on, and we've had lots of courses already. So it'd be great if we could hear from some of you all about experiences that you've had, questions that you may have, if you've started implementing any of the teaching, if you have questions about how to implement any of the teaching. Now is a great time to ask those questions.
Yeah, I think that it would be really interesting, especially if anybody's been able to implement anything they've learned to hear about that to begin with. Feel free to unmute yourselves if you have something you'd like to share or something you have a question about.
Hello.
Hello.
Yeah, I think we can start. Nobody's asking. So let me ask. I asked this question during the lecture from Dr. Price that, as I said, if we are doing IMRT for a long time, so, but in terms of the patient-specific QA, the failure rate is very low. So again, so what kind of schedule should we put so that we can reduce the workload as well at the same time we cannot, miss any kind of the protocols we have regarding the patient-specific IMRT? What does the AAPM suggest for that?
Yes, actually it's been some time since we started our program, but we still try to adhere to some of the original scheduling that we came up with. Initially, we were asking for 8 days of time between the initial simulation and treatment start. And that may need to vary depending upon your individual clinic, the type of cases that you're doing, what your experience level is at that time, your overall caseload as well. But this was to give primarily the physicians time to delineate their structures, interact with the planners, give the planners time to generate as optimal plans as they can, have additional interaction with the physicians, go through the process of approval, all the data transfer, all the physics checks, and then patient-specific QA. So this seems like a long time, 8 days, but it's not really all that long. And the biggest holdups are primarily the physicians. If you have only 8 days and they assign a treatment start to the patient goes home, they're coming in on a Monday, let's say. If the physician doesn't give you delineate the contours you're going to need for your target and critical structures for 3 days, well, we're cutting things down. Then also, once we get plans that we believe are optimal, we need that interaction with the physician for approval. Many times this will need to be multi-iterations because the physicians are also learning as well. They're going to have to learn what you can actually achieve. And invariably, initially, they will say, well, I would like to see this, or I would like to see that. I would like to improve here or there. After a while, everyone learns together and you can decrease that process. But as you saw in one of the slides I showed, even today, 40% of our cases go to delivery QA the night before the start. So that leaves very little time. If you have a problem, let's say QA was delivered at 8 o'clock last night, the patient starts, I do try not to have them start before 11 in the morning to give us time to do the analysis in the morning and to remedy any problems that we may encounter. There's very little time to fix things. If let's say you start at 8 o'clock, you have 3 hours and the patient's going to be here. If it's a catastrophic error, then you need to cancel the patient. So early on, you're not going to necessarily know what a catastrophic error may be. When I'm calling catastrophic, I mean where you just cannot accept. So I would advise, don't do QA the night before if at all possible. I'm still battling this. I've been our clinic chief for 23 years now. I'm battling this every day. I hate this portion. If I could have 2 days, that's always better. I hate to have to tell them, we can't start Mrs. Jones because I'm uncomfortable with this and she's here. So then, but I think it's very good to get the physicians on board, get administrators on board, whoever is going to be in the process of scheduling patients, make sure you have enough time and try to stick to that as best you can. The time will never get bigger. It's always going to decrease. So try to start with a generous time between simulation and treatment start. And as you gain experience, in my opinion, then you may be able to decrease that somewhat. So that's.
So one way I've started thinking about this is, yes, for the majority of our patients, everything will be fine and the QA will pass. So we as physicists tend to think statistically, oh, it only affects 0.01% of our patients. But for that one patient, it's 100% of their lives. And I've had family go through radiation therapy, and once you flip your mindset and relate that to other people who are pressuring you and saying, hey, think about this one patient who's 100% dependent on this, you usually get a lot more cooperation to make space for that QA. Now, I know that Cesar and his site in Memorial Sloan Kettering, they have, after extensive validation work, changed tack a little bit compared to most of us. So I would be interesting to hear his perspective.
Ready? Yes. Hi, Sonia, and everyone else. Nice to see you virtually, all of you guys around the world, I guess. Can you hear well? Perfect. So yes, as Sonia said, we are kind of unique in that part, that we basically, because of the extensive IMRT QA that we have done in the past 6 years, we don't do anymore patient-specific QA right before the treatment. We do it for SRS cases, that is a single fraction, or for some SBRT, we still do it, and we use EPID for that, portal dosimetry, because that's those very high doses, and we haven't get past that. But I agree with all of you, even though we do not do the patient-specific QA, because like Sonia said, the majority of the patient will pass. And we have other checks, actually. It's not that we don't have anything else. We have dynalog checks and trajectory log checks that we can rely that that's what is going to be delivered. So it's not that we ignore it. So we have to replace it with some other methods. But I think it's very, very important to account for the QA time before the patient is being treated, because in general in the clinic, like you all know, things get busy. Physicians come to things late. The planners scramble to do plans quicker, but it always will eat the time of the end, which I personally think is basically the most important. The plan check, which is part of the QA, and the patient-specific QA. So we also have like a similar schedule, like from SIM to treatment for regular cases. We have like a 7-day period, which we have allocated time to do the contours, the planning, the planners, the QA day, which means the plan check day, and then the treatment the next day. So I think it's very important to make sure that you don't eat the time for the QA, because it's very important. And even if it's that 1% patient that you might think that it's not going to be okay, you need to be careful. I mean, you shouldn't bypass that, and with whatever method you're doing for the QA.
Just a cross question, sorry. You mentioned the dialog files. Do you really rely on the dialog files because it's all about the mechanical accuracy of the MLCs?
Yes, we do. And we do rely on that for all the, conventional cases and all that, yes.
I think it's good to point out that the best approach is to follow right now TG 218 and the recommendations from Dr. Price on his last lecture. And just to keep in mind that Memorial Sloan Kettering is a big academic institution with lots of history, lots of physicists looking at data, making analyzations. And, they transitioned from more traditional patient-specific QA devices towards log-based QA. And that was a methodical approach. And so from our group and from the AAPM, the recommendation is still using some various sorts of real measurement devices, whether it's chamber and film, portal dosimetry, an array device, or something of the like. And just to touch on, real quickly, the pass rates. So I think it's important also to not get complacent. If you see lots and lots of pass rates, maybe the passing criteria are not so stringent. And so it's been shown in a number of studies that a number of measurement-based patient-specific QA devices have some difficulty of actually picking up differences in the plan and the delivery. And sometimes this is based on criteria that aren't very stringent. So, for example, two things that I've done at my hospitals. One is I have a passing criteria that I use. And so you got your tolerance limit and your action limit based on a particular gamma analysis. But then what I'll do on each patient, I'll lower the gamma, the distance to agreement, and the absolute dose difference. And I'll see at what point the plan fails. And I'll sort of keep track of this from patient to patient. The other thing, and this was a recommendation by TG 218, is to keep track of your IMRT QA patients by planner, by modality, by machine, by energy, and you can start tracking tendencies. So if there are tendencies, a certain planner has more failing, then maybe look at that planner. Is that planner planning with higher modulation? Are certain areas failing more than others? Are spine cases failing and pelvis cases are not? It's a nice way to track your patients and to sort of analyze, what's really happening. And by lowering that gamma and taking a deeper assessment, you can really look at any sort of systematic differences that you might have.
Yeah, I wanted to just give a heads up that the APM is, together with ASTRO, is trying to organize a summit on IMRT QA, because we have realized that compared to when we started the current IMRT QA process to now, technology has changed. We're doing more and more adaptive planning also. And there's a lot more science on IMRT QA. And I recommend, we probably can send a notice out when that is scheduled. Since it is all a virtual meeting, we hope that we can get also international attendees, and just to learn more about the deep dive into IMRT QA. I wanted that to mention here, and just in case you have the opportunity to attend virtually once that is scheduled.
And I'll make one more point. Sorry if I'm talking so much about this. I think it's important to really pay attention to your results. So sometimes I do the same. I get complacent sometimes, and I neglect to realize details that have maybe been more obvious than I thought. So for example, in the past, I've seen the use of two devices for analyzing patient-specific QA, portal dosimetry and Mobius 3D. And Mobius 3D is basically its own independent system with independent TrueBeam data for the TrueBeam machine. And everything is based on a standard. Now, TrueBeams don't change much from TrueBeam to TrueBeam. They can, but typically they're sort of a fine range. And so I noticed that there was a systematic difference in mean dose of PTVs in Mobius, and that wasn't being picked up in the other patient-specific QA. This is when I first arrived at a hospital, so I didn't really know the history of machines or anything like that. So I decided, okay, Mobius is systematically showing this difference. Let me look into the data. So I opened up Beam Config. I looked in there. I looked at the commissioning reports, and I saw that the dosimetric leaf gap appeared to be quite small relative to the sort of standard range of dosimetric leaf gaps for that particular energy on TrueBeams. Then I looked at the commissioning report, and the commissioning report showed the dosimetric leaf gap was measured by the varying method only and not corrected. So they didn't do any measurement iterations using TG119, no IMRT or VMAT specific measurements to fine tune that DLG. And so typically when you fine tune this DLG, the DLG value increases slightly. And I didn't see that. And then it started making more sense. And that the TPS, which was having a smaller DLG, was showing less dose than was actually supposedly delivered by Mobius. And I looked back at the data from this institution on that, and I saw that the TLD values from IROC were that my TPS was showing, again signifying maybe the wrong DLG. And so, you know, using all the devices at hand, and my portal dosimetry at the time was not picking it up, but Mobius was. So I decided, okay, instead of just ignoring it, let me look into it a little bit deeper. And it allowed me, when I first transitioned to a new hospital, to see a possible deficiency in the actual beam modeling.
Very, very good points. Thank you for those opinions on that. Staying on portal dosimetry, there's a couple of people who had questions about, I guess, the steps to getting portal dosimetry up and running in a clinic once they have the license and everything on the varying machines. Would any of you be able to speak to those concerns? I guess maybe technically the challenges or the steps?
I use Suncheck as my portal dosimetry software. Would that apply here?
Sanj, I'm not sure what Suncheck is.
Oh yeah, Suncheck is a product written by Sun Nuclear, which is a QA device and software vendor in the United States out of Florida. And they basically use the EPID dosimetry, the portal dosimetry data to provide portal dosimetry QA. It's very similar in concept to the Varian and Electa products. So I'm not sure what the specific question is.
Well, I think the most important thing about if you're going to commission portal dosimetry, so I'm speaking, I have not actually commissioned it myself. Some of my colleagues did that at my institutions. But it's important to speak with the manufacturer first of all. So they will give you clear instructions, a tutorial, step-by-step of what steps that you need to take and where you need to put that beam data. So the first thing is to get those instructions directly from the vendor. And then, you know, collect that data, input the data, and make your test measurements and preferably compare those test measurements to another device that you have. Ion chambers being the gold standard. So finding areas of high dose and areas of low dose on your IMRT QA plans with not very much gradient. So you want a nice flat area of high dose, a nice flat area of low dose. Take ion chamber measurements, preferably with a small ion chamber. And you want to do that for a lot of plans to rule out any sort of random error with gradients and that sort of thing. And use those chamber measurements to compare to your portal dosimetry measurements. But in terms of a step-by-step to step-by-step instructions, I think the best step would be just to contact the vendor, and they should supply exactly what that is. And of course, if you have questions during that process, we would be happy to look at it with you and to help you troubleshoot.
Yeah, so I'm just commissioning it for the second time because I'm moving from a beta testing to a clinical software. The first step is usually to calibrate the EPID according to the manufacturer's instructions. And these are usually flood field calibrations to take out the backscatter from the arm and a couple of other things. And the details tend to be very vendor specific. So there should be instructions from the vendor. And then depending on the software you're using, for my software, I have to shoot a number of fields that is pretty actually automated. The vendor provides these for me. I just need to get them into Mosaic and deliver them. These are usually narrow fields across the whole EPID to check out any variations in detector sensitivity and some flood fields, and that then gets processed and I get a result how well that QA is. There's also often some settings on the EPID on the machine side that need to be changed, for example, the frame rate and some other things, but that also should come in very detailed instructions from the vendor. The next step, as Adam has said, I've run a lot of QA plans in parallel, so I used my QA device. It happened to be an Suncheck and measured my plans, and then I used the EPID for the same patients. And then I just compared pass rates. They're slightly different because an EPID has a lot more data points. Also, the software gives me slightly different things. So I had to really think about, okay, what is a pass fail here? What is a pass fail there? What is an appropriate gamma setting? Do I want to look at other parameters? So that took a little bit of time. In the end, EPID QA is a lot faster because you don't have to set up a device. So that's really helpful for busy clinics because you can teach your therapists to do it. And if they have a little gap because the next patient is late, they can just shove the couch out of the way and make the measurement. On the other hand, there are limitations of EPID QA. The major one I have found is for very long fields. You don't want to do these on the EPID because you are irradiating the electronics that are sitting on the periphery. So depending on what EPID you have, your manufacturer will give you the maximum field size on the EPID that you should irradiate. You have to be a bit careful because you have the magnification, so you need to figure out what the limitations are. So yes, for about 80% of patients, I've been able to move to EPID for patient-specific QA, but we have a lot of head and neck patients at UC Davis with very long fields. Sometimes the prostates with nodes also reach the limit, and those I still have to do on a traditional device.
My question related to portal dosimetry is from Dr. Bryce. That I know in some institutions they are only using the portal dosimetry. So is this, advisable? It is something logical to use the same software to check the software by the vendor again in case of the variant. If you want to check the beam, the calculated by some particular algorithm, and you are checking again their own product by using their own algorithm. So independently using portal dosimetry, is it something which is not very, because you don't know what kind of algorithm they are using to check their own product?
We don't currently use dosimetry, but I think exactly what Sonia said a moment ago. If I were to implement this tomorrow, well, it wouldn't be in one day, but I think I would look at an ancillary system or our current system that we're using, and I would do those comparisons. I would have less issues with doing the vendor-specific software comparisons that you're alluding to if I had a secondary system that I'm already comfortable with, and I'm making those cross calibrations, if you will, those cross comparisons. But to start, I think you bring up some good points. To start out directly like that, I'm not necessarily sure I would feel so comfortable. There are many things you could start with. You could start with film. Film's going to give you obviously the great resolution. It's just time intensive. The ion chamber, as Adam said, is the gold standard. So these types of things, and then I would compare that with the portal dosimetry. I don't know that I would start out just with portal dosimetry. I personally might feel uncomfortable with that.
It's a good answer, Dr. Price. And I think I may expand just a little bit more that even once you're using portal dosimetry, again, this is a perpendicular field assessment, which is not ideal. I'm not saying it's not good, but according to, again, AAPM TG 218, it's not the gold standard of IMRT QA. I would still spot check it. So maybe on your monthly QA, you get a chamber out or a chamber and film, whatever your other devices are, and just do a spot check on some interval that it's still behaving as it's supposed to be behaving, and that if there are any other issues with the delivery, say dose rate with gantry speed, that sort of thing that wouldn't be picked up, that it would be picked up on this extra, say, monthly QA or quarterly QA to sort of check that device. And then the last thing would be with any device that you're using for measurement to QA that device. So portal dosimetry, for example, before each measurement, it's good to check for example, the output consistency of portal dosimetry, that the values are in agreement with what they should be, and to do a little bit more rigorous QA on a monthly basis.
Yes, I agree with that. And that's a good suggestion because we do, even though we don't do daily portal of IMRT specific QA in our clinic, but we still do it for SRS and SVRT cases. So we do spot checks monthly, and that's very important because it gives you a good, confidence that you are, doing a good job. And especially because we do it for SRS cases, something that I want to mention is you also need to pay attention when you're using portal dosimetry for small fields, because things change there too. So you will need to tweak algorithms and things just to make it and calibrate it basically for small fields. And we have done it. Again, we have a group here that specifically have done that. I don't know the exact details, but it's just to mention that something needs to be on mind. And we got a lot of guidance from the vendor, that's another point that everybody talked. I think it's very, very important to talk to the vendor because they do have very specific steps. And most of them, they will follow the DGs in general, what the DGs will suggest. But, if you have any doubt, it's very detailed what they can give you. So, and also stress the small fields, dosimetry too.
Thank you guys again. It looks like at the moment we don't have any additional questions. I'll just remind people they can feel free to unmute themselves. I was wondering if you guys, in the meantime, have any opinions, and maybe you've kind of hit on it a little bit, on running your patient-specific QA as just a secondary calculation and increasing the amount of monthly QA that you're doing and not actually running a patient plan on the machines. I'm sure that this has been, a point within the community that people want to get away from actually running these patient QAs on the machine. And I don't know if you have any opinion on whether that'll be an acceptable solution at some point or what the difficulties there will be.
I can give a quick opinion. We have decided, or we have to date stayed with delivery QA primarily. Even as Sonia said, and someone else had mentioned how good our passing rate was from the top. I went to our chairman a few years ago, when we were at about 10,000 patients, and I could count maybe 10 that would have been 10 QAs that would have had some kind of severe deleterious effect to the patient. And I said, this is whatever, 0.1%. I'll take that every time. Exactly what Sonia said. That for statistically, that's great. But for that one patient, it's catastrophic. And there have been catastrophic errors where it's typically when someone edits something or we have an issue with something getting transferred. If you're if you lose data on the way to the record and verify system, to the LINAC, and you don't have the modulation, the leaf sequence, let's say, but you have those monitor units, you can have extreme overdose, right? So in this case, something needs to check this, in my opinion. We do it via the delivery. You can do this via the log files because you're basically delivering with nothing there. You could do it with portal dosage, something. But just to say, okay, I have a plan in the planning system and I'm going to export it to an ancillary system to do another dose calculation. We've already commissioned and checked that algorithm with respect to how accurate it is. And anything else is basically arithmetic, in my opinion. We're not checking the problem that I just outlined. And it only takes one time, and then something very, very bad could happen. So while it is a pain, we have chosen to stay with it. Even further, it would be nice, as I showed in the slides on the progression, would be to take those log files and recalculate on the patient CT data set. Some systems will even let you map a cone beam CT, map the original CT to this and recalculate based on delivery so that you can actually have patient-specific metrics with respect to organs at risk, target coverage, this kind of thing, which you're not going to be able to get unless you have what actually happened with the accelerator. Am I able to deliver what I planned? So rather than going away from that, I would think going towards that would be even more beneficial, more clinical, if you will. But that's just my opinion.
One more, just one comment regarding, especially for head and neck cases, just like we know that the AAA is underestimating the doses. In case of, for example, the nasopharyngeal carcinoma with the cranial extension, where in the septum, if there are air cavities, you will see there is a breakdown of isodose lines and it's underestimating. But in actual, we are directly radiating the fluence on a water phantom or on a water slabs putting by 2D array or something. So we are really checking in a water. We are not basically checking whether is it encountering that kind of inhomogeneity or not. So in reality, it's not actually giving us the real comparison that what's going on inside the patient. So sometimes it's giving us the wrong picture, in my opinion.
I guess, as I mentioned in one of my very first slides on Monday, that we need to distinguish between commissioning that algorithm and QA. We commissioned AAA again. We have a very big Monte Carlo contingent at Fox Chase. So we commissioned our routine AAA algorithm against full-blown Monte Carlo. We understand what the inherent discrepancies are, these types of things. So the idea and its use when we're actually delivering on that solid water phantom, we're not checking that. We're checking because we've calculated with AAA on a solid water phantom, right? No heterogeneity, basically. The idea is when we deliver to that same thing, can we reproduce that? I think the portion that you're asking is the step before that. How accurate was AAA in the heterogeneous environment? That needs to be other checks. I believe there are other lectures, if they're not already given, on this very thing. Maybe someone else can chime in?
I completely agree, Dr. Price. That's a good answer. And two separate things that we're checking. Again, there's, like Dr. Price said, there's the commissioning of your algorithm. Dr. Price is lucky enough to have two separate algorithms to check the same thing, Monte Carlo and AAA. I think he said he used AAA as well in that case. There are other methods of using phantoms and measurement devices. There are secondary check systems, third-party systems. So there are lots of ways, and there will be a lecture that covers a lot of this. But just to reiterate what Dr. Price said, two separate things that we're checking, the delivery and the algorithm.
To
come back to the patient-specific QA. The more I think about it, the more complicated it gets. We're seeing more and more adaptive therapy, especially head and neck cancers you just mentioned. There are significant changes over the course of their treatment. But to require patient-specific QA for each of these adaptive plans becomes at some point really prohibitively complicated. And especially we're seeing more and more machines which can do these adaptive plans on the fly. So the Varian Halcyon is one example, the ViewRay system. So this really has pushed the question that you were asking, how much do we really need to do? What do we gain? What do we lose? And I don't have an answer to that, to be honest. There's also data out of Seattle from Eric Ford's group that show that pre-treatment patient-specific QA can find some errors, but what's actually more effective is a first fraction portal dosimetry-based QA that finds a ton more stuff like incorrect shifts in the plan and other things. So if I'm thinking about having limited resources and I only have so many people in my clinic, where do I put them most effectively? If I don't do adaptive QA because it's too much patient-specific QA work, I might find that one patient in 1,000 where in the pre-treatment QA I find an error, but on the other hand, I deny other patients the advantages and less toxicity of having an adaptive plan delivered to them. So I'm still honestly very much struggling with this, and just one step of the time feeling my way forward, trying to make a risk-benefit decisions in my clinic with and trying not to bias myself toward the easier route. But it is very, very complicated once you think about it in more details. And it also depends a lot on your specific clinic, specific resources, the case mix you have. It is different in each clinic, each country.
Sonia, can I ask you something on that? Comment? It's just because you brought out a very good point, because adaptive therapy is becoming much more common in many sites, head and necks, and we do a lot of GI case here, adapted as well. But so have you come out with a system to replace that IMRT QA for the adaptive plans? Or let's say, for example, if you compare, you compare what you did, the IMRT QA for the original plan, and if it was good, and then if the changes weren't that much between one plan to another, do you trust not to do it, or you do it anyway?
So I think what I'm going to do now that I have a clinic portal dosimetry software system, I'll start running in vivo dosimetry. And once I trust that for that first fraction, we can have a discussion on would we trust that for an adaptive plan, and would we be okay given the specific patients if anything were to go wrong on that one in vivo dosimetry fraction to accept that. And that is a discussion I need to have with my physician. So clearly SBRT is out of a question because you have no opportunity to fix any mistakes. Head and neck or prostate with, well, prostate you don't adapt, but head and neck is a typical case, or maybe lung, advanced lung cancer where the tumor tends to shrink. If the patient has 30 fractions and I'm QAing at fraction 10 or 15, maybe that getting that one fraction not perfect is acceptable as long as it's not catastrophic. And given the fact that we usually have 2 arcs for head and neck patients, if I run the QA, if I look at the analysis of that in vivo dosimetry after the first arc, I could probably immediately see if there is a catastrophic thing going on. So I don't even have the full dose delivered. So that's my thought where I'm going, but it does require getting on the same page with the physician, getting them comfortable and well educated on the technology. Yeah, and then just see. Also in the US, I have to say there are legal considerations we have to consider. again, that is different from country to country. We have what we call a tort system. So if something goes wrong with the treatment or there's toxicity, there's sometimes a high risk that patients can sue. And so hospital administration also drives safety from that angle that is not necessarily a scientific angle. So that's a different topic, but I want you all to be aware of, because I don't know your countries. I've only lived in 2 countries, Germany and the US, which are very different in that regard. But also please think about this in your country. It's a fact of life that you cannot ignore those things.
I would like to make a comment. I'm not necessarily sure of the cross-section of all the people on this call with respect to where they are. I know previous to the talks, I was under the impression that many had not yet started IMRT. Okay, and they're in different phases of starting from 3D CRT to forward. We need to be cognizant of that. And I don't think any of us would have jumped from 3D to adaptive immediately. There has to be those steps. So with this in mind, and knowing the hurdles that we had to jump, the things that we've had to encounter over the last 20 years of IMRT, I think that's very valuable information. I don't think we should make the jump between 3D and adaptive, which is our most extreme. We should jump each of those hurdles at a time. Whether or not we stay with them for 20 years or whatever, that there's no reason to reinvent the wheel. But the idea is we need to make sure we don't do something catastrophic. So as we go through each one of those processes, I think the delivery QA has a very important place. It will help teach us. It helps keep us from making bad decisions in many cases. And as we progress, we can progress faster than we did, because we didn't have these types of things. When we started IMRT, there was no one to ask. The only people that were doing it were Cesar and his group. Charlie was and they had done 2 before we did ours. And some folks at Baylor were doing it, but there were no one to call. So here we have whole courses on this. I just want to make sure that we don't miss out on that potential learning, and where this can be afforded so that we can not hurt people, I guess is what I would say.
Completely agree with you. I think the trick of doing IMRT well is doing it one step at a time, slowly, and give yourself time to assess and learn, and then take the next step. Yeah.
Dr. Price, I missed your lecture this week. Did you by any chance hand out that Excel sheet with the keeping track of IMRT QA by different parameters?
I did not, because I didn't know if you wanted me to hand that out. It was your sheet. So
yeah, sure. So no problem. So for everyone on the call and those that aren't on the call, I'll distribute an Excel sheet to everyone, which already has drop-down lists, so you can filter your IMRT QA. And I think it would be something really helpful for everyone to do, no matter where you are in the process, whether you're just beginning or if you've already used it quite a bit. It lets you keep track of how things are doing by site, by passing criteria, by doctor, by physicist, by dosimetrist, by patient-specific QA type. So it'll let you really see these trends and where you are. The other thing that I want to point out is that we're available in this process. So if you're just starting IMRT QA, and if you're just starting the conversation with the vendor about how to implement it, like we had some of those questions earlier, we're here to help, not just the 4 of us, but all of the educators in this program. You know, schedule, if you need some one-on-one help, schedule a call with us, a video call, and we can sort of go in and troubleshoot and, you know, just have a collegial discussion about which devices you're using, how you're using them, what sort of passing rates are you getting, and how to proceed. So like Dr. Price said, he didn't have that when he first started. Now we all do. So I definitely use that to my advantage. Whenever I'm doing something, I reach out to my friends everywhere, and I ask for their help, their opinion, that sort of thing. So hopefully this is expanded everyone's network. So use other people at other centers in this call, use the educators, but we're here for that network to assist along the way.
Dr. Schulman, for the generous reminder for everyone to reach out. There's about 5 minutes left. There's 2 questions, I guess, that maybe we can touch on very quickly. The first involves dosimetry, and I know we don't necessarily want to jump there right away, but maybe there's a quick comment somebody could make on performing that in vivo dosimetry and kind of where it's at, whether there's commercial products available or if this is all being done in-house at this point still.
Anja, do you want to touch on that since you have any experience with it? I know you touched on that earlier. I have not used it myself.
I know that she was in the middle of dealing with a down machine, so she may.
I'm sorry, can you repeat the question? I'm the only physicist in the department today and I have a down machine, so I'm slightly distracted occasionally. Very sorry for that.
Yeah, so the question, just very quickly, because we only have a few minutes left and there's another question to get to, is involving performing in vivo dosimetry. If you have just a maybe quick comment and kind of what the state of it is, if it's all just done in-house or if there's any like commercial solutions.
So I'm only aware of one commercial solution right now because I'm not familiar with the Varian or Elekta solutions. So they might take that with a grain of salt. So I use the Sun Nuclear solution. It is relatively straightforward, but I have to say, I find it very valuable information because it does find things that we don't see in the pre-treatment QA, but it also requires resources. So I think from step 1 to 100 of implementing IMRT QA, I would put that somewhere at 80 or 90. It is very valuable if you have the resources to do, but I think there's higher yield things you need to address first.
Okay, thank you. And then the last question that I wanted to get to, someone asked about performing MLC QA tests and what kind of, I guess, software or documents or plan files do you need and how can you get them? If they're vendor specific, are there any open source softwares or things to help with that?
So from my experience, you can get a lot of these files directly from the vendor. Again, they may be vendor specific, vendor to vendor. And there's a lot of different software packages that you can use.
Sorry, Dr. Schulman, you're breaking up a little bit because of the wind. If you could repeat maybe the last 10 seconds.
Yeah, sorry. So there are vendor specific, in my experience, software packages that you can use as well. I've used a number from a number of different companies. I'm not sure firsthand if there are any open source software that you can use, just because I haven't had to use it. I can look into that. I'm not sure if anyone else has any other experience. And if you're implementing MLC QA, we'll be happy to help with your specific center, your specific equipment, and your specific needs, because this MLC QA is very valuable. It's necessary to check on a weekly and monthly basis, depending on the measurement. I would argue that the MLC QA is as valuable or more valuable than an actual patient-specific QA. So something definitely not to neglect.
Okay. Thank you. Thanks to all of our educators. It is the top of the hour. I don't know if there are additional questions or if anyone has time to stay on, but it is the top of the hour. So thanks everyone for your time. Thanks to all the attendees for participating. And I think hopefully it was a very valuable discussion. I learned some things, so hopefully everyone else did too.
Yep, and hopefully we'll hear more questions via email or text or phone call.